I'm very thankful to Chairman Dr. Naroli for introducing me to this audience. And this talk, innovations in communicable diseases, is very important because communicable diseases is so in brief we will discuss about the new innovations in communicable diseases. As you brief outline of the problem, communicable disease prevention and treatment, and the new innovations in the management of life-threatening infections like dengue, malaria, and HIV. The talk has been divided into 4 parts. Now coming to the burden of this communicable disease, about 15 million people die each year due to infectious diseases. AIDS claims about 2.6 million deaths. Respiratory infections, 3.5 million deaths occur due to respiratory infections. Due to tuberculosis, about 1.5 million deaths occur. Malaria claims about 1.1 million deaths. And measles in the Western world and the developing countries also, about 9 lakhs deaths occur due to measles. So the burden of communicable diseases is very great, and new innovations are required for the prevention and treatment and also cure of these communicable diseases. The green dots, the medicines medicines exist, but R&D is required to improve the security for the patients. The blue dots, you see the medicines exist, but new R&D is required. And the pink dots, no medicines are available, no good medicines are available till now for these diseases. So take for example HIV/AIDS. We don't have any good drugs for prevention. We have got drugs for treatment, but there is no drug for cure. As in tuberculosis, we are having drugs, but there are no good drugs for prevention, because of recurrence of this drug resistance, newer drugs are required. In malaria also, there is no good drug for prevention. For treatment, we have drugs. For cure, we have drugs, but the problem of resistance is there, and so new inventions are required. For childhood diseases, you see there are drugs, but they all have to be updated because the bacteria are multiplying and new mutants are developing, and the problem of resistance is greatly increasing. For cancer also, there is no good drug, no proper drug as such or vaccine for prevention. For treatment, we have drugs, but there is no definite cure for cancer as such. For neuropsychiatric disorders, you see there are drugs for treatment, but there is no drug for prevention and proper cure of the disease. So as for diabetes also, you see we have drugs, but they cannot cure it. You can we can only just treat it. For respiratory infections also, we see we have drugs, but there is no cure for it as such. So there is a current gap in the management of communicable disease. There is no cure for HIV/AIDS. There is no effective vaccine available for prevention of HIV, TB, malaria, dengue, etc. And there is lack of effective antimicrobial against multi-drug resistant MDR TB. Next. Now, the biomarkers for bacterial infections. The current biomarkers are raised WBC count, raised C-reactive protein, tumor necrosis factor, TNF-alpha, and interleukins like IL-6 and IL-8 are increased. And these are the current biomarkers which are being used. But there are newer biomarkers in development also, like lipopolysaccharide binding proteins, the LBP, procalcitonin, pro-CT levels, and we can also analyze the exhaled volatile organic compounds by non-invasive methods, and they can also. The utility of procalcitonin, which is a new biomarker. If the level is less than 0.1 microgram per deciliter, antibiotics are strongly discouraged per deciliter, then antibiotic therapy is recommended. And if it's more than 0.5, then the antibiotic is strongly recommended. So useless use of antibiotics is can be prevented if you are doing a procalcitonin test. If it is being done regularly and if the cost comes down. Antibiotic therapy indicates are indicated if the level is above 0.26 microgram per liter, deciliter. It also helps to differentiate between bacterial and viral infections. Elevated levels predict mortality critically in patients. The higher the level, the more the critical the patient is. And it also is a guide for the judicious use of antibiotics. And the sequential pro-CD levels are an excellent guide for duration of antibiotic therapy. If the pro-CD levels are going down with treatment, and if it comes below this 0.26, then we can taper off the antibiotics. Then there's another marker that, which is very easy to do in outdoor setting, exhaled volatile organic compounds. The volatile organic compounds are only nitric oxide, hydrocarbons, nitrogen, oxygen and sulfur containing compounds, and this can be collected by exhaled breath or exhaled breath condensate or induced sputum. This is a non-invasive test to assess air inflammation and oxidative stress. Previously, these invasive methods like bronchoalveolar lavage, bronchial mucus biopsy and transbronchial lung biopsy was being used. But now with these non-invasive methods and the assessment of these volatile organic compounds, we can also diagnose these respiratory diseases. Total these VOCs, which is the gold standard test, then electronic nose, e-nose also is called, proton transfer reduction mass spectroscopy, selected iron core tube mass spectroscopy, ion mobility spectrometer and laser spectroscopy. These are available in the West, and these are being introduced also in India in the metros. And gold nanoparticle sensors, which can also analyze these VOCs, and so we can make a diagnosis of these respiratory problems. Different VOCs are exhaled in different diseases, and so that is called breath print. And the potential clinical uses are for the diagnosis of TB, cystic fibrosis, asthma, COPD, lung cancer, because the different VOCs are being exhaled in the different diseases. And this is also particularly useful in children. Back as 1921 BCG vaccine was introduced. 1936 solid culture for this culture of this tubercle bacilli was also introduced. 1943 streptomycin was discovered, which was very effective in those days. And 1963 the discovery of rifampicin, caprimycin was discovered. 1934 to 80, with the advent of TB and HIV co-infections, the emergence of MDR-TB started to show roots, and the treatment of tuberculosis became more difficult with the emergence of these resistant strains. And 2010, we introduced the introduction of Gene Expert MTB-RIF diagnostic tool, which is approved by WHO, has revolutionized the diagnosis of tuberculosis. As you know, the TB bacteria is caused by Mycobacterium tuberculosis. It enters the human host and replicates inside the. Now, for diagnosis, we can do the antigen detection test, like a LAM test. LAM is a protein which is very specific for tubercular bacilli, and this can be detected in the urine also. And so, because sputum collection is a very big problem in our country, because most of the patients give us a sample of contaminated sputum, or only they are giving the saliva, and so the results of sputum examination is not visualization of the bacteria can be done by LED microscope. Normally fluorescent microscopy and this UV light was being used previously. Now with the advent of LED microscopes, that also increases the microscopic results are very good, because the bacteria are seen more clearly. Then the culture also, the culture based detection tests like MODS, which can and this thin layer agar phase based the other tests like colorimetric media, which there's change of color due to the presence of bacteria, that is also being used. And the other tests which are more specific is the nucleic acid amplification test like LAMP, XPART, and DNA and genotype, and MDR-TB+. These are the name of the test. And as I mentioned earlier about the volatile organic compounds, that can be also analyzed for detection of tubercular bacilli. And as the TB bacteria enters the body, there is immune response, And then you can measure cellular immune response by IFN gamma assays like the quantiferon gamma gold test, the spot test, and the other skin tests also which are being developed, which are very more specific than the BCG test. And the humoral immune response antibody detection. The serological test for the diagnosis of active relevance in India. They detect the humoral immune response IgG, IgM, IgA to the Mycobacterium tuberculosis. Currently about 1.5 million tests, mainly ELISA were performed every year for the diagnosis of active TB in India. Approximate cost was about ₹825 million per year. These tests are very inaccurate and imprecise, and there is high risk of misdiagnosis of TB with these tests. And they are not recommended by any international guidelines and not used in any developed country. They were being used extensively in India before 2011. There are so many tests. You find there's a list of suppliers who are supplying these ELISA kits, and they claimed as for the package insert. Some said they were 100% specific, 99% sensitivity. Some claimed 100% specificity and sensitivity. But there's a long list of these tests which were being done in India. In July 2011, WHO issued a policy stating that commercial serological tests provide inconsistent and imprecise estimate of sensitivity and specificity. There are high proportion of false positive and false negative results with these tests. And this, the use was discouraged by WHO and also the National TB Control Program. And the Health Ministry and the DGCI have banned the import and sale of TB serological tests because they are doing more harm than good, because we are over-diagnosing or under-diagnosing tuberculosis. The system detects TB bacteria, that is a background test, and the other MGID and another test. And the most important one which we came on in 2010 is the automated detection of an MDR screening. This device allows automated sample processing, DNA amplification of the TB bacteria is done, and detection of Mycobacterium tuberculosis and screening of rifampicin resistance can be also done. This test is called Gene Expert device, and this can be carried by a machine. Then the molecular line assay strip test simultaneously detects TB bacteria and genetic mutation also. And these tests are called MTB plus and MTBDR-SL. Then the TB specific antigens can be also detected from the liquid or solid cultures to confirm the presence of Mycobacterium tuberculosis. These are Cadila TB rapid diagnostic test. These are in pipeline. But the first major breakthrough in TB diagnosis since sputum smear examination was the Gene Expert MTB assay. This is a rapid and fully automated nucleic acid amplification test. This provides simultaneous diagnosis of TB and also the genotype rifampicin resistance. You can also give the bacilli is resistant to rifampicin. It yields positive diagnosis in 99 to 100% of patients with smear positive, and in 57-23% of patients with also smear negative pulmonary tuberculosis. It has a sensitivity of 81.3% for extra pulmonary tuberculosis also. You see, this is the machine. The sample reagent is added to raw sputum or any other removal inhibitors, ultrasonic lysosomes, and everything occurs by the machine. And this is a real-time PCR, polymerase chain reaction test, and the results are available within 2 hours only. If the patient is waiting in your clinic, if he comes to the hospital, he can wait for 2 hours and he can get the results of this test. And this is particularly very useful to TB patients with HIV co-infections and suspected cases of MDR TB. As I said, this sensitivity is 97% and the specificity is 99%. Then there are other immune modulated tests like MDR plus and MDR plus SL. These are also established for diagnosis as well for knowing the drug resistance. The first one is the genotype MTB-R plus and the genotype MTB-RS, and these are DNA strip technology. DNA is extracted from the sample material or specific amplified via PCR. This is all done to rifampicin isoniazide, and the second test also detects resistance to fluoroquinolones, aminoglycosides, and other drugs like inflammasome. And the starting material for these tests are pulmonary patient specimens or the cultivated samples from the liquid or solid media. And this test takes about approximately 5 hours, and both these tests takes about only 5 hours. The benefits results are available in 5 hours. It allows early and appropriate treatment for MDR-TB and also helps to reduce the burden and spread of MDR-TB. And the other tests which are being is useful in diagnosis of TB and HIV with the co-infected patients. This was about tuberculosis. Now coming to the innovative vaccines under development. About 300 vaccines are in development, and the research focuses on prevention and treatment. Out of these 300 vaccines, about 196, the first vaccine for smallpox was developed. 1885, rabies vaccine was developed. 1962, the polio vaccine was developed. 1981, hepatitis B vaccine was developed. 2003, nasal flu vaccine was developed. 2007, avian flu vaccine was developed. And the first therapeutic vaccine for cancer was developed in 2010. And recently also, yesterday also, there was in the news that new anti-cancer vaccine has been developed, which is costing about 45,000 rupees only. So there are many vaccines in development. You see there are many applications submitted. Some are in phase 2 trial, some are in phase 1, some are in phase 3. And for infectious diseases, there are, the most number of vaccines are developed, 137. For allergy also, vaccines are being developed. For cancer also they are being developed. For neurological disorders and others, constitute about 30 of these 300 vaccines which are being developed. Currently, BC is the only available vaccine for TB. It has a poor protective efficacy and it ranges from 0 to 80%. Now the two sets of TB vaccines are under development. One is a BCG replacement vaccine which will replace the BCG vaccines, and other the boosters with the BCG vaccine. The BCG replacement vaccines are the RBC30, a genetically modified disease strain which overexpresses this protein, and this is a replacement vaccine for BCG. And another is the VIP1002, which is a recombinant BCG vaccine engineered to overexpress this protein, and this is this gives more specific protection against tuberculosis. And the other type are the boosters for BCG vaccine, like recombinant strain of modified vaccine Ankara virus expressing this from AG85 from Mycobacterium tuberculosis is being developed. And the Russell AD85 is also recombinant vaccine. There is the M72 vaccine, which is protein adjuvant vaccine. So in 2010 there were about 11 candidate vaccines being evaluated in clinical trials. The two TB vaccines, the MBA85 and ERAS-402, are currently being developed in efficacy trials, and they have entered the phase 2 trials for safety and efficacy. And these two vaccines have entered the phase 2 trials. The other are in phase 1, some in the other are in phase 3 also, because they are entering the safety and efficacy trials. So this is a list of vaccines which are being evaluated in different countries, from Tanzania to South Africa to Gambia to Senegal and Philippines, and the results will be known somewhere around 2019 to 2020. Some research has come from China also. Chinese researchers have developed a vaccine that acts simultaneously against Mycobacterium tuberculosis and HIV also. This vaccine is currently undergoing preclinical trials, and we will be knowing more about it in some time later. Now coming to the innovation, the drug therapy of tuberculosis. Because this drug therapy of tuberculosis has become more important with the advent of MDR-TB. According to WHO estimate, up to 500,000 new cases of MDR-TB are occurring every year globally. Nearly 4% of all these TB cases are drug resistant. 1 in 5 TB patients who have previously received TB treatment are estimated to have been drug resistant. Barely 1 in 20 TB patients are tested for drug resistance, because we are not doing drug resistance tests routinely. And out of the 94,000 patients detected to MDR-TB, only 77,000 patients began treatment. The rest were not started on treatment. So the problem of MDR-TB is underdiagnosis and under-treatment of this MDR-TB. And the limitations of the current drugs for MDR-TB are because also active against the dormant bacilli, because they can be used in the treatment of latent tuberculosis also. The novel anti-TB drugs under development are The nitropentazole derivatives like OPC 67683, which are the phase 2 trials. The oxazolidine derivatives, which are being developed by Pfizer and AstraZeneca, they are also in phase 1 and phase 2 trials. And there is another SQ109, which is in phase 2 trials. But this dialogquinone, which is TNC207 or beta-quinone drug, which has been developed and approved by US FDA also, and it might be shortly available in India also for treatment. The dosage regimen is about 400 mg daily for first 2 weeks, followed by 200 mg 3 times per week for 22 weeks. And the duration of treatment is 6 months. So the duration of MDR-TB can be cut short very drastically with the introduction of this drug. There is another drug, delamine, never develop into adults. So when they never develop into adults, so they are not able to transmit the protein and the vaccine, the virus. And the successful field trials have been conducted in Brazil, Malaysia, and the Cayman Islands. And he has also received the Wellcome Trust Award for this in 2011. But many vaccines have been development for dengue vaccine. Doing research on this for prevention of dengue fever. This has entered the phase 1 trial. There is a Denvax hybrid vaccine. This is also being developed in USA. This is also entered phase 1 trials. And this GlaxoSmithKline has also come with dengue DNA vaccine for prevention. This is in the phase 2 trials. And DNA vaccine is also by Sanofi also. This is fast track. The name is fast track, and this is in the phase 3 trials. And this might be shortly available also. The malaria vaccines also, for prevention of malaria, many vaccines are in the development. Some have entered the phase 1, phase 2, and the recent one, this is a list. And other vaccines, the Mosquirix malaria vaccine, which is a recombinant vaccine, which is being developed by GlaxoSmithKline, and this has entered the phase 3 trials and will communicable diseases promptly and more effectively in the future. Thank you.